you once again, all the participants, panelists, dignitaries, and respected people. Today, we are having one of its new episode of the webinar series that we are holding on behalf of Dr. Chaturvedi Cancer Hospital Private Limited and Research Institute, and with the members of the Oncology Integrated Society group. Today we have eminent panelists from various disciplinaries of radiation oncology, medical oncology, surgical oncology, and maxillofacial surgery. And so we have kept this broad topic of head and neck cancers, which is very difficult to complete in itself, because every topic has many minor topics to be discussed. But today we'll be taking only gross outline of the commonest problems in head and neck cancers. And so I'll start with the introduction, small series of the panelists. First one is Dr. Alok Tiwari, surgical oncologist. He is MBBS, MS, DNB, super specialty, ESSO, breast oncoplasty, FALS, colorectal, FMAS, DIP MAS, hepatobiliary, Da Vinci, XI certified robotic oncosurgeon, HOD, surgical oncology director, Synergy Institute of Cancer Care and Research Institute. So, and his work experience is immense. He has been doing his, he started his career in 2009 and he is practicing till date. And he has many publications and papers to his credits and many fellowships and memberships of Delhi Medical Council, UP Medical Council, Haryana Medical Council, IAGES, AMASI, and European Society of Gynec Oncology. He has many academic records, all those that have been already told, from New Delhi, Lucknow, and UP. He is one of the very finest human being and finest surgeon. Yes, Dr. Alok Tiwari, I'm talking about you. Are you here or I'm just speaking about you?
Yeah, ma'am, thank you.
Thank you. You have, you have come through
Gaurav.
the mobile of Gaurav Popli. That's why I was thinking, where are you? And is he there? Next, I'll tell about him.
Yes, ma'am, I'm also here.
We are all working together in Panchia Hospital.
Synergy, ma'am, synergy.
I don't think I have his CV with me. Okay. Can you project, Mr. Varun, his CV? Mr. Gaurav Popli. Right. If you can see Dr. Chaturvedi, do you mind reading?
Ma'am, I will introduce myself.
He's saying I'll introduce myself.
Yes, ma'am. Basically, I'm a maxillofacial from background, and since last 5 years, I'm into oncology.
Put your video on.
Sure, ma'am.
Yeah. Both of you are side by side.
Yes, ma'am. Yes. So I'm a maxillofacial by background, and from last 5 years, I'm into oncology only. Initially, I did my postdoctoral fellowship in Dharamshila Cancer Hospital. It was in 2017 to 2018. Later on, I went through FHNO, Foundation of Head and Neck Oncology, to pursue fellowship in oral oncology at Mazumdar Shah Cancer Center. It's in Bangalore from 2019 to 2021. In between, I went for the 3 months to Hong Kong also for the plastic reconstructive surgery fellowship. And later on, since 2021, I'm into Synergy Cancer Center, Gorakhpur. It's been almost 2 years. I'm completing. And also I'm pursuing a senior management program in healthcare and analytics from IIM Kozhikode.
Oh, so nice of you to give your kind introduction, and sorry for the error. After this, I'd like to introduce Dr. Saurabh Mishra, who is a medical oncologist, and he is practicing in Lucknow, Medanta, and also in Panacea. And he has done his matriculation, 12th, everything he has written. MBBS from KGMC, Lucknow, internship from Allahabad, MD Medicine from Meerut, Medical College Meerut, senior residency from RML, IMS Lucknow, DNB from Medanta Cancer Institute. And is very, very excellent medical oncologist. He has been with us since few years, and we know him to be a very good person and a humble person, down to earth. And his personality traits are dealing with patient complaints about the quality of service of the practicing evidence-based medicine, able to lead and motivate staff, ability to prioritize workloads during the busy schedule, just like he's doing now in the car. His work experience from 2014 till now. Senior resident in nephrology, Medanta Cancer Institute, consultant, medical oncology, Max Healthcare, New Delhi, consultant, medical oncology, Medanta, Medicity, Gurgaon. And he has research papers, and he has been co-guide in DNB, medical oncology, on the topic prospective observational study for early prediction beta protein complex associated with chemotherapeutic and targeted anti-cancer agents in multiple myeloma, a tertiary cancer center. Very good. Welcome, Dr. Saurabh.
Thank you, ma'am. Thank you.
Dr. Ayush ka Varun ke paas hoga. So he'll project, and Dr. Chaturvedi will read. I have the CV of Dr. Poonam Gupta. She cancer.
Hello. 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 Hello.
Then details of her work experience. Baba Theratron, telecobalt unit, Theratron, telecobalt unit, HDR, brachytherapy, simulator, tapes, OPD work, chemotherapy, CECT for RTP, Electa and variant TrueBeam, 3D CRT, IMRT, IGRT, VMAT, electron treatment. Research work, role of adjuvant radiotherapy and chemotherapy in post-surgical patients of high-risk oral cavity cancer. So that's very important. Hello, Dr. Poonam.
Yes, ma'am.
Research. When did you get this done? Research.
This was done in my MD duration.
During MD times. Okay. Good topic. A very common cancer, 39%. Feasibility, study of hypofractionated radiotherapy in breast carcinoma, feasibility study of hypofractionated radiotherapy, again, UP chapter AROI, and in Journal of Cancer Volume 50 supplement. There are many paper presentations and poster presentation and participation in quiz and exhibitions, and there is a list, innumerable list, what to see, 40. So many of them as a participation. And she has a great working experience and good knowledge. So all credits to you, radiation oncologist, Dr. Poonam. We had with us Dr. Sonia also. She is also a wonderful human being, a radiation oncologist at Allahabad. And when the story of Akil Ahmed began, we were at Lucknow and there was a Dhara 144 installed, and there was all scare everywhere because that was from, the person belonged to Allahabad itself. And the incidence was also of Allahabad. So over to you, Dr. A.K. Chaturvedi. Please introduce Dr. Sonia because I don't have her CV. Now just read it out, it is there.
Recording in progress.
Mr. Varun, please change the CV. Acha. Have we not read it full? I think so. We are done with Dr. Sonia, and kindly post Dr. Ayush Garg CV.
Recording in progress.
And under 40 category in the Young Change Maker Summit and Award 22. Number of publications, international 2, national 10. So welcome Dr. Ayush Garg to this panel. So today we all have gathered here and this panel is constituted to come to the conclusion, what should we do? Because head and neck cancer, this is most common cancer and nearly 30% of the total malignancies in India and developing countries. Whereas in the American countries, it is 4% only. So see the gravity of situation and it's fairly common. So we'll discuss about the management of oral cancer incidences and we'll go to every panelist one by one. And these are very simple questionnaires, which in day-to-day life, we are facing these problems. So we'll see what we can find out of this. So my first question is to Dr. Poonam. Dr. Poonam?
Yes, sir.
Yes, sir.
Yeah. Can you tell me what type of cancer you are seeing in Uttar Hospital and what's the incidence of head and neck cancer?
Sir,
Roughly?
in this hospital, sir, maximum cases are
Because worldwide it is 30%.
Yeah. In this hospital, sir, in oral cavity cancer, or if we consider all head neck cancer, almost I think 40 to 50% patient coming with head neck cancer, including buccal mucosa, tongue, and oropharynx, palate, and larynx. And the CA tongue and buccal mucosa is very common among all.
Okay. Now, what all cancers are included in head and neck? Which are the type of malignancy? Which site is included in head and neck cancers?
Sir, oral cavity and oropharynx and larynx.
Right. Hypopharyngeal and laryngeal, lip, oral cavity, and nasopharyngeal,
Oropharynx
oropharyngeal.
also, yes, sir.
Yes. PNS. These are the common cancers. Salivary gland tumor also included in this. So these are the few cancers. Can you elaborate what could be the possible cause of having such a
Actually, addiction of tobacco and alcohol, this is the main cause. Hello.
some voice? I'm not able to hear.
Hello.
Okay.
Tobacco and gutka chewing is the most common cause for the oral cancer.
Yes, very true. Very true. Tobacco, alcohol, few viruses, HPV, EBV virus. These are quite common, and these are.
Yes, sir.
Any other addition, Dr. Sonia?
Yes, sir. So most common cancer are the mainly in the this area is head and neck cancer, in this oral cavity cancer, and the oropharyngeal, hypopharynx, and larynx. In oral cavity, most common is the buccal mucosa and the gingivo buccal sulcus, and tongue also. These are very commonly we seen in routine practice. And the most common cause is obviously this tobacco chewing in any form, smoking, or the tobacco doing in the gutka, kheni, in any form with betel nut, with pan, and with betel nut and all these things that we know. And alcohol is also the, if taking alcohol with tobacco. So mostly the common cancers are the pharyngeal cancer with alcohol, and laryngeal also with
Very
smoking.
right.
And other is the viral infections, as you said.
Yeah.
And
So
mostly
it has
patient
been
present with
observed
the, yes,
regarding viral infections, it has been
Yes.
observed that HPV virus
yes,
normally
commonly in
affect
the oral cavity and oropharyngeal mostly, but
Oropharynx
routinely
is,
we are not doing these viral to HPV viral infection, because this is not possible in our setup to do all these patients, to identify all these virus infection. So, but as we all know by literature and seeing, so that's why. And
Yeah.
other things are patient mostly present with the leukoplakia and sub mucosal fibrosis. And
we
after
are
that,
coming
we
to-
see, yes,
Yeah. So this HPV virus mostly it affects oropharynx, and
yes,
EBV virus nasopharyngeal
Nasopharyngeal,
carcinomas are
yes.
common. And vitamin A deficiency, poor nutrition,
Yes,
these are also
yes,
contributory
yes.
factors which are responsible for head and neck cancers.
Mostly happen.
Now, Dr. Popli,
Yes, sir.
Dr. Popli, this is for oral cancer. Which are the precancerous lesion, and what percentage of changes they change into cancers? How to avoid their changes? So what are the precancerous lesion?
If we see WHO has divided pre-malignant conditions as well as pre-malignant lesions. We have divided basically in two parts. Pre-malignant lesions are different and conditions are different. And lesions include leukoplakia or submucous fibrosis. And, other conditions, generally lichen planus is the most common. And in case of leukoplakia and erythroplakia, second leukoplakia has more incidence of conversion, chances of metastasis to the more chances of conversion, malignant conversion. And erythroplakia, almost 50% chance is there in cases of erythroplakia, and as well as oral this thing, verrucous carcinoma. They have also divided included oral. Verrucous carcinoma is also included in this thing only. Condition lesion.
Verrucous carcinoma is already carcinoma. So leukoplakia, erythroplakia, chronic candidiasis, submucous fibrosis, these are predisposing factors, or in fact precancerous lesion, syphilitic, glossitis. So these are few things which over a period of time, it takes 10 to 20 years approximately to convert it into cancer. So,
Actually, we're talking about a polycystic leukoplakia, verrucous leukoplakia, PVL.
now, can you say something about which is the rarest site of the cancer, head and neck cancer? Site-wise, which is the part which is rarely involved?
Actually, sir, it depends upon the location. It depends upon the demography as well as. See, if we'll go to the eastern part of India, in Assam and Manipur area, nasopharyngeal is quite common. But in our part, in the part of Uttar Pradesh as well as Bihar, it is less, comparatively very less.
It is rare. Yes, yes, very true. And which is the commonest?
Commonest is oral cavity in our part.
Yeah, correct.
Like I was in Hong Kong, we used to see a lot of nasopharyngeal cancers there.
But overall, global incidence is nasopharyngeal is rarest.
Overall, nasopharyngeal is the rarest.
Yes, yes, yes. Now, what are the diagnostic tools for deciding how to proceed further?
For oral cavity cancer, this thing only, observation as well as clinical examination is the primary thing. And if it's going to the posterior part of the tongue or the oropharynx or larynx, Then fiber optic laryngoscopy, we additionally we examine through the this thing only, and the gold standard is histopathology only. Histopathology only gives the final diagnosis for cancer.
There is some audio problem. Okay.
Now I'm audible, sir.
Yes, sir, you are audible.
Yeah. So for the clinical diagnosis, only histopathology is the only gold standard. And for the staging, we go for generally CECT or the CA-MRI of head and neck.
Yes, that's very true. And what about the molecular diagnostic test?
So actually, in head and neck, none of the molecular diagnostic test is totally proven. That is totally dependent as per evidence.
I think Dr. Saurabh will tell us in a better way. Dr. Saurabh,
Yes, sir.
he is a
So,
medical oncologist.
So, sir, molecular test has no implication on, you can say, in the treatment or in diagnosis as well. But yes, some prognostic significance is there. So, for some P16 expression testing by ISC, sometimes for nasopharyngeal carcinoma, we testing Epstein-Barr virus and their ISH by in situ hybridization and all. But there is no role in, you can say, deciding the treatment right now. Even some trials has been designed for the effectiveness of the drug as per the P16 markers, but that has also not proven very significant.
But if it's a locally advanced stage 4, then probably PDL1 still comes in picture.
PDL1.
Yeah, so
PDL1
definitely
for
in
recurrent.
locally advanced setting. So PDL1 is now a marker up to some validated that you can
PDL1
use
is, people are doing. And genomic and protein profile of salivary.
salivary gland
For
tumors
early
we do for
detection.
tumor agnostic therapies in
Yes.
metastatic setting when you do NGS testing and all. Yes.
How does it help in going for the treatment?
So, sir, I have done, I think, last year, I will tell only not from that previous one. So, I have done in like 4 or 5 patients in salivary gland tumor. I haven't found actually any targeted therapy for those patients. So, yes, if it is AR receptor positive, then we have a drug. If anti-RK, that is mentioned everywhere, if it is positive, there is a drug. But practically, I haven't found any mutation by doing NGS. But yes, if there is a mutation, it will help up to some extent in a tumor agnostic form.
So is there a germline marker test? And what is the privilege in treatment? And after knowing this,
sir, germline, I don't think I know any germline marker.
Actually,
for right now.
sir is actually talking about this Lynch syndrome and Fanconi's anemia probably. So they are not very common. But if you have a family history of say these things, then you can probably search for Lynch syndrome or Fanconi's.
Sir, normally germline, if you see that hereditary oral cancer are one itself very rare things.
Yeah, uncommon.
And heavy association, so cyclin dependent kinase 2 के कुछ स्टडीज में आया है, बट प्रैक्टिकली मुझे नहीं लगता कि हम लोगों ने तो अपनी लाइफ में अब तक नहीं देखा कि कभी कोई हेरिडिटरी ओरल कैंसर का पेशेंट ही अपनी अब तक की क्लिनिकल प्रैक्टिस में नहीं देखा है जहाँ पे आइसोलेटेड हेरिडिटरी ओरल कैंसर की हिस्ट्री रही हो फैमिली में. So don't know कि बस CDK1/2A का रोल था कुछ केसेस में, but there are very few reported cases.
okay. Dr. Alok Tiwari,
Ayush.
उसके बाद ले लेंगे उसको लास्ट में पहले. What should be the aim of surgery in treating head and neck cancer?
Sir, in like any cancer surgery, the first and foremost aim is to get the complete R0 resection if you are doing surgery. Second thing is as much as possible organ preservation to alleviate the dysfunctionality that we normally get with oral cavity cancer, and as much as possible to rehabilitate the patient as soon as they can regain their normal lifestyle. So जो सर उसमें वही है कि डिजीज फ्री रखना है उनको लेस इज मोर के कॉन्सेप्ट पे अब हम ओरल कैविटी में भी काम करते हैं कि जहाँ पे हम मिनिमम डैमेज करें बट ऑप्टिमल सर्जिकल रिजल्ट मेंटेन रखते हुए उनको कंप्लीट फंक्शनैलिटी प्रोवाइड करें।
Good. What is the prognostic value of frozen section T1, T2 carcinoma oral cavity? Prognostic value.
सर T1 T2 प्रोग्नोस्टिक वैल्यू फ्रोजन में अगर आपका मार्जिन क्लोज है, पहली बात तो अगर गुड सर्जन है और नॉर्मल अचीवेबल लोकेशन पे ओरल कैविटीज में क्लोज मार्जिन का सिचुएशन आती नहीं है T1 T2 में। एनाटॉमिकली आरएमटी पे या कहीं पे बहुत छोटा लीजन है जहाँ पे आपको लग रहा है या टंग में आपको लग रहा है कि फंक्शनल प्रिजर्वेशन के लिए आप बहुत क्लोज जाना चाह रहे हो, तभी इश्यू आता है। अदरवाइज T1 T2 में नॉर्मली हम फ्रोजन कराते ही नहीं हैं, केवल उन लीजन्स में कराते हैं जिन लीजन्स में हमें लगता है कि ये प्री मैलिग्नेंट हैं या वेल्कस कार्सिनोमा है जहाँ पे हमें लग रहा है कि हो सकता है बेसमेंट मेम्ब्रेन क्रॉस कर रहा हो, दैट सिचुएशंस में हम फ्रोजन यूज कर रहे हैं। अदरवाइज प्रैक्टिकली हम T1 T2 में फ्रोजन यूज नहीं करते हैं, एंड इट इज इजी इन एवरी लोकेशन यू गेट अ गुड मार्जिन। सो क्लोज मार्जिन में मार्जिन पॉजिटिविटी है या कोई इंसिडेंटल आपको लीजन मिल गया है इंट्रा ऑपरेटिवली जिसमें आपको लग रहा है कि ये मे बी मैलिग्नेंट हो सकता है और वो आपके फील्ड से बियॉन्ड हो जाए, सेकंड प्राइमरी मिल गई है वहां पे, तो देन यू कैन। अदरवाइज ये देखा गया अगर आपने मार्जिन पॉजिटिव रिसेक्शन किया है और फ्रोजन के बाद आप रीगेन करते हो नॉर्मल मार्जिन, तब भी ओएस डिफरेंस नहीं है। तो वंस यू हैव ट्यूमर सेंसिटी, ट्यूमर बाउंड्री की है, तो उसके बाद आपका ओएस एडवांटेज आता नहीं है, भले आप रिवाइज मार्जिन ले लो।
Nowadays, lot of cases we are seeing for carcinoma tongue. Now, the treatment of cancer tongue depends upon which factor? How will you proceed?
Depend on number one is biology and इनमें क्या है कि आपके लिम्फोमा भी हो सकते हैं, आपका ड्यूडीज के साइड पे आपका स्टोन सेल कार्सिनोमा भी हो सकता है, देन आपका ट्यूमर की लोकेशन, ट्यूमर की साइज, उसके नोडल स्टेशन के और टोटल न्यूट्रिशनल एंड फंक्शनल स्टेटस ऑफ द पेशेंट, उससे डिसाइड करते हैं कि हम ट्रीटमेंट क्या प्रोसीड करेंगे। लोकली एडवांस अगर है और रिसेक्टेबल है तो ऑब्वियसली इन हेड एंड नेक कैंसर और फर्स्ट एंड फॉरमोस्ट चॉइस इज गोइंग फॉर सर्जरी। Patient is nutritionally poor or any other way it is not good for the surgical candidate, then we choose the second option of chemoradiation or neoadjuvant chemo or induction chemo, followed by we take the decision whether we will go for surgery or we will go for the chemo, definitive radiation.
Now nowadays we are getting early cases. Now what's the latest treatment for the oral cavity cancers in early stages?
सर अर्ली स्टेजेस में है कि अभी जो हम लोग यहाँ पे प्रैक्टिस कर रहे हैं उसमें एक केवल हमने चेंज किया है कि जहाँ पे हम ट्यूमर हमारा 4 मिलीमीटर से लेस डेप्थ का है वहाँ पे हम नेक, अगर हमारे पास N0 नेक थी तो वी डोंट डू नेक डिसेक्शन, वी कीप इट देम फॉर ऑब्जर्वेशन एंड वी गो फॉर द थेरेप्यूटिक नेक डिसेक्शन। बट अगर हमारा डेप्थ ऑफ इन्वेजन मोर देन 4 है तो हम सारे पेशेंट में सेम वही वाइड लोकल एक्सिजन कर रहे हैं, अकॉर्डिंग उनका रिकंस्ट्रक्शन कर रहे हैं एंड देन आपका इलेक्टिव नेक डिसेक्शन सारे केसेस में कर ही रहे हैं अप टू 1 to 4। 5 रेयरली हमने यहाँ पे किए हैं जिनमें हमारे को अगर नोट्स पॉजिटिव मिल रहे हैं, क्योंकि यहाँ पे केसेस मिक्सअप टाइप के आ रहे हैं। ओवरऑल अगर आप देखिए तो पिछले साल में हम लोगों ने लगे 368 किए हैं टोटल यहाँ पे हेड एंड नेक कैंसर सर्जरी, एंड आउट ऑफ 368 आई थिंक हार्डली 4 या 5 होंगे जिनमें हमने नेक ऑब्जर्वेशन के लिए रखी है, वरना सारे में हमने नेक डिसेक्शन किया ही किया है। और रेडिकल नेक डिसेक्शन हाँ कंपैरेटिवली रेयर हुए हैं, रेडिकल नेक डिसेक्शन हार्डली 10 to 12 केसेस में है।
We are talking about early malignancies, carcinoma in situ type of thing.
MND3 कर रहे हैं, वाइड लोकल एक्सिजन विद MND3 एंड रिकंस्ट्रक्शन अकॉर्डिंग टू द लोकेशन।
So somebody is doing Mohs surgery in which they just take out the upper layer of involved area and with wide margins.
There is now the role of compartment dissection in tongue, जहाँ पे हम मस्कुलर प्रिजर्वेशन मैक्सिमम करने की कोशिश करते हैं, बट मोस्ट ये सब प्रैक्टिकली इन सब सेंटर्स पे या इवन इंडिया में करने के लिए ना तो आपके सर्जन जो भी पैथोलॉजिकल साइड से भी अच्छे हैं, क्योंकि मोस्ट में आपको खुद ही आइडियल स्लाइड बनानी है और खुद ही देखनी है। So as per my knowledge, I don't know
how far the pathological report is reliable when you see a big mass with carcinoma in situ. Use fungating mass and the report is carcinoma in situ. How will you proceed?
प्रॉब्लम यहाँ पे क्या ना कि अब जैसे अपनी सिटीज में प्रॉब्लम है कि यहाँ पे कैब गाइडलाइन पे पैथोलॉजी रिपोर्टिंग होती ही नहीं है।
सही बात है।
हाँ तो नहीं सर, अब डीडी रिपोर्ट करने लग गया है कैब गाइडलाइंस में, बाकी सेंटर से रिपोर्ट उतना ज्यादा है नहीं अभी।
Now, what's your take for advanced stage carcinoma of tongue? If it
Sir,
comes to you, how will you proceed? Advanced.
एडवांस कार्सिनोमा टंग में अगर बीओटी इन्वॉल्व नहीं है, एंटीरियर पार्ट केवल इन्वॉल्व है और इवन नॉन रिसेक्टेबल है, कई बार क्या होता है कि फ्लोर ऑफ माउथ बहुत ज्यादा है इन्वॉल्वमेंट या हमें ईमा बहुत ज्यादा मिल रहा है स्किन पे, उन सारे पेशेंट पे हम यहाँ पे इंडक्शन कीमोथेरेपी देते हैं और वी हैव सक्सेसफुली ट्रीटेड 14 केसेस हमने सर किए हैं यहाँ पे, जिसमें हमने सौरभ विल टेल मोर कि वी हैव यूज्ड अ मॉडिफाइड डीसीएफ प्रोटोकॉल as a neoadjuvant chemotherapy, and after that we have to go for the total glossectomy by pull-through approaches. और मोस्ट माउथ में हमने रेडियल फोरआर्म या फिर यूएनसी रिकंस्ट्रक्शन किया है
एंड ऑलमोस्ट 1 ईयर फॉलोअप पे अभी तक जस्ट रिकंस 1 ही है, 1 और 2, हां 2 पेशेंट्स में रिकंस आउट ऑफ 14.
2 वाइट 14 है सर हमारा रिकंस रेट, तो क्वाइट डिसेंट है. अभी हम लोग 20 पे हम लोगों ने सोचा कि वी पब्लिश दिस डेटा.
If a patient is having carcinoma posterior third of tongue, how will you proceed surgically?
इसमें सर यहाँ पे तो नॉर्मली हम लोग सीटीआरटी के लिए कर देते हैं कि पेशेंट गो फॉर द सीटीआरटी ओनली. लिम्फोमा अगर है देन लेट्स गो फॉर द कीमोथेरेपी ओनली.
Any other person have any other point of view for the advanced carcinoma tongue? Dr. Pankaj?
Sir, for the advanced carcinoma of the tongue, if the patient is not resectable or borderline resectables, then we can try the directly chemoradiation or the neoadjuvant, but we know there is not much role of neoadjuvant chemotherapy in the carcinoma tongue, but sometimes the patient is like that, we can try the neoadjuvant chemotherapy. Then if the patient is resectable, then assess for the surgery. If resectable, then post-op adjuvant therapy, if possible. Otherwise, directly we can take the patient for chemoradiation.
एक्चुअली ये टाटा के इशू के साथ कंट्रोवर्सी हुई थी कि न्यू एडजुवेंट कीमोथेरेपी का रोल ओरल कैविटी में नहीं है. तो केवल अनिल डिक्रूज सर की स्टडी जो थी उसमें हम लोगों ने ईसीएफ यूज नहीं किया था.
Yes, but some patients are responding well to the neoadjuvant chemotherapy. Not all, but some patients are very well respond to the neoadjuvant chemotherapy. Then we can take the patient, borderline patient, for surgery.
But
we are not having many trials regarding pre-op radiation followed by surgery and then again radiation plus chemotherapy.
Yes.
Do we have any other such type of trials? Dr. Tiwari.
Actually, no head-to-head comparison of these treatment, neoadjuvant followed by surgery or then post-op adjuvant therapy. So there are the few studies that shows there is some that because of neoadjuvant chemotherapy, we can downstage the tumor. Yes. Then
Dr. Alok Tiwari. Fortunately, both are Tiwari. We can discuss it. Yeah. Dr. Alok?
Surgeon is always pro for surgery first. And second thing, obviously, when there is a neoadjuvant radiation is used, then obviously it becomes difficult for us to go for surgical resection. As per my knowledge, there is no definitive trial where pre-op radiation is used.
Yes.
Not in head and neck, we have seen in other parts.
Sir, my question, sir, one query. Sir, how the neoadjuvant or induction does help surgeons in downstaging? Please, surgeons, they can give some idea. I don't think it much help in downstaging actually.
No, sir.
It's not downstaging.
No. Yeah. Why the surgeon choose neoadjuvant chemotherapy? Per se, I will say. Obviously, I have told that if you see the difficulty that we face after neoadjuvant doing surgery, because आपका margin blur हो जाता है, ट्यूमर जब तक delineated होता है, because how we are resecting tumor, after time we rely on the palpation method. तो palpate करना हमारे difficult हो जाता है ट्यूमर response पे. लेकिन neoadjuvant से हमें इतना idea लग जाता है कि अगर disease responding है हमारी neoadjuvant chemotherapy को या induction chemotherapy को, so that disease will give a good response to surgery also. Second, कई बार होता है कि patient nutritionally poor है. In that time, we are not able to perform a bigger surgery. So morbidity और minimize करने के लिए disease progression ना हो plus हमें disease response पता चल जाएगा. वो NACT हमें help कर देती है. मार्जिन की जहां तक बात है या रिसेक्शन मार्जिन जो हमारा प्रायर होता है वो आज भी हम जो हमारी प्रायर MRI रिपोर्ट होती है उसके अकॉर्डिंग ही हम प्लान करते हैं. बट ये दो हेल्प डेफिनेटली मिलती है और उनमें प्रोग्नोसिस की बेटर
Resection line will be the same.
Section will be
As
same.
we have seen
Basically,
in the initially, and this is whether it is chemotherapy or it is pre-op radiation, this will facilitate the surgeon to do a better surgery, but the margin will not reduce. You have to take out all the things.
It gives you a better direction about the biology of the disease, that how disease is going to be.
Absolutely. Now, what is the commando operation? Normally we listen every time, and how it is more useful than CT and RT?
I think Gaurav will do.
Advanced stage. Chaliye. Gaurav, Popli.
Basically, commando operation is a composite dissection. Basically, it includes combined mandibular dissection as well as neck dissection, where we try to take the complete tissue in a toto without taking the other. We are removing the bony if required, as well as soft tissue, as well as mucosa in a combined way. So that's why it is called as combined. Basically, combined mandibulectomy as well as neck dissection. So.
One more thing is OPG.
Sir, I think one commando, I think name we routinely not use now. It is wide local excision is more commonly used now.
Yeah, composite dissection with wide local excision plus minus whether we are doing any segmental or
There is a lot
commando
of
is modified.
So commando is sir acronym actually इसका origin कहाँ से है exactly properly नहीं पता. There just be stories are there. So कि जो सर्जन कमांडो की तरह इतना लंबा ऑपरेशंस करता है. सेकंड था कि वर्ल्ड वॉर 2 में फेशियल इंजरीज के बहुत पेशेंट होते थे, तो डेब्राइडमेंट और ये करने के लिए जो इंटर्न थे दे यूज्ड टू वर्क लाइक अ कमांडो, तो उनकी सर्जरीज को बोला जाता है कमांडो लग गया. फिर उस एक्रोनिम को यूज करके जबरदस्ती हम लोगों ने उसको बना दिया कि ये करके कंबाइन कंपोजिट मैंडिबुलेक्टमी डिसेक्शन ये. बट नाउ बाय
exactly there is no nothing.
It is not a scientific acronym.
Specifically not a scientific commando.
One thing nowadays very much seen, OPG. Now, how it is going to help?
Sir, I think OPG only helps us in the early detection of this thing only involving where the CA. Yes, sir. Carcinoma is involving lower alveolus. Yes. Otherwise, it is not, and it doesn't have a good sensitivity. Sensitivity is very low, almost 70% is there. Instead, if we go for the MRI has a sensitivity of around 90 to 95%, and the specificity of CT is also almost 90%. So, doesn't help so much OPG.
Are you using titanium implants?
Yes, sir, we are using titanium implants, but titanium implants we are using only cases of benign lesions, not for malignant lesions. Because whenever we are reconstructing for malignant lesions, we only prefer free flaps, fibular flaps, because there is a high chance of exposure of the titanium implants after radiation. So we try to use the titanium implants only in cases of benign lesions like amyloblastomas.
Right. Yes. Now my question to Dr. Ayush Garg.
Yes, sir.
Ayush, indication for RT alone or RT plus CT in head and neck cancer?
In RT alone, usually it depends upon tumor size. Usually T2 and above.
Sound थोड़ा कम हो रही है, mic के पास आओ.
Sir, usually T2 and above, अगर disease है, LVI positive, perineural invasion is positive, margins are positive, or there is nodal involvement, or there is extra capsular extension. So these are basically major absolute criteria for adjuvant radiotherapy. And if we consider for adding chemotherapy along with radiotherapy, then basically there are two criteria: extra capsular extension and margin positive. So these are two absolute criteria which we study or which we have read in trial textbooks, that these are the major two absolute criteria. Otherwise, for adding chemotherapy, there are many relative criteria as well, like all the absolute criteria of adjuvant radiotherapy are relative criteria for adding chemotherapy as well, like close margins, or depth of invasion is more than 4 mm, or tumor size is more than 3 or 4 centimeter, or LVI positivity, perineural imaging positivity. So these can be relative criteria. But if we see absolute for adding chemotherapy, then we practice extra capsule extension and margin positive. If these two criteria are there, then we do add chemotherapy along with adjuvant radiotherapy. Otherwise, our medical oncologist
where you
colleagues
will advise RT only, no CT.
So in cases, if these two criteria, first of all, needs to be negative, like extra capsule extension and margin should be negative. And apart from these, if tumor is T2 tumor, node positive,
Yes.
LVI positive, PNI positive, or the depth of invasion is more than 4 millimeters. So these are basically absolute criteria for adding only radiotherapy and not chemotherapy.
Only
Negative.
one node positive, T2 tumor, T1, T2, and without any other high risk factor. If there is other high risk factor, more than one node positive, then add the chemotherapy.
CTRT.
Yes.
Now what happens, because most of the time patient भाग जाता है, हफ्ते भर बैठ गया, या sometimes deliberately we say okay, give 1 week gap and then we will restart again. So should there be a break during RT? When and where?
Sir, usually sir, RT में break ideally नहीं होना चाहिए, because
yes,
if we give RT break, then there is a loss in local control. In many trials it has been seen, agar more than 1 week का gap है, तो local control is as less approximately 10 to 12%. So local control, if and secondly, if we are giving a treatment break, then we need to increase the radiotherapy dose as per the radiobiological principle, because tumor is repopulating. So encountering that, we don't need to break. Otherwise, the only indication is when patient is unable to tolerate the chemotherapy or radiotherapy, or there are intolerable side effects like grade 3 mucositis or grade 3 skin reactions. In those cases, we need to stop radiotherapy. Otherwise, patient won't be able to continue radiotherapy further. So in such cases,
we have to do gap correction and all.
Yes,
just
so
to improve
gap correction, and even increase the dose of radiation as well, so that we can just change the dose of radiation of that period which was not given radiotherapy, during which the patient was not given radiotherapy.
Is there any role of radiotherapy in CA larynx, early stage cancer? This is for our surgical colleagues and.
Yes, sir. Sir, actually, there are not many head-on trials in which radiotherapy is compared with surgery in early stage laryngeal cancers. But yes, there are few trials, few meta-analysis which have compared. So they have showed that there is equivalent results of surgery and radiotherapy. So as we are now moving more towards organ preservation, so maybe we can keep surgery as a salvage option in future recurrences, because overall survival is same when compared surgery with radiotherapy in few trials. So surgery can be kept as an salvage option for future.
Salvage option. Yes. Dr. Alok, any other opinion?
There is one change in surgical side, sir. It has seen that when you do surgery in T1, T2 lesion, whether it is your oropharyngeal or your vocal cord lesions, इनमें there is de-escalation of radiation doses now. आपका 70 ग्रेड 66 ग्रेड के बजाय 54 ग्रेड के नीचे का de-escalation के ट्रायल्स हैं, और खासकर जहाँ पे हम माइक्रोलैरिंजियल सर्जरी या रोबोटिक सर्जरी के थ्रू ये चीजें कर रहे हैं, वहाँ पे आपका पोस्ट ऑफ आरटी का डोजिंग कम हो सकती है. बाकी अगर अर्ली T1 लीजन्स हैं तो इवन माइक्रोलैरिंजियल सर्जरी है सेम ओवरऑल रिजल्ट, और ऑर्गन प्रिजर्वेशन सेम है उनमें. The only disadvantage, because in any macrolesion surgeries we get is कि हमें tracheostomy करनी पड़ जाती है. So हम prefer इसीलिए करते हैं कि T1 T2 में वो कर दें, radiation के लिए चला जाए. But
organ preservation and voice
But
everything
still,
is
sir,
okay.
मतलब as oncologists, we should always counsel the patient. मतलब उन्हें surgery का भी option देना
What do you
चाहिए
what
and
do you want?
radiotherapy का भी option देना चाहिए, because it is the patient's right to decide. We should tell the pros and cons, and the patient should decide whether he is willing for surgery or he is willing for radiotherapy. Because if we just can't just put the pressure on the patient that no, you have come to me, so you have to go do radiotherapy.
Do
We
the
have to
treatment.
explain him, meet once the surgeon, and then decide whether you want to go ahead with surgery or radiotherapy.
Yeah,
It's not what
problem comes in the real scenario, like why we prefer to go for radiation in early laryngeal cancer patient, because obviously we are getting advantage of organ preservation. Another advantage is because these patients are not into that kind of frame of mind. काउंसलिंग करना और प्रैक्टिकल में काउंसलिंग समझ पाने में डिफरेंस है इंडियन माइंडसेट में। और यहाँ पे आपके पास जहाँ पे पेशेंट वेल इन्फॉर्म नहीं है, वहाँ पे बहुत बार क्या होता है कि आपको लॉजिस्टिक इश्यूज के साथ चूज करना पड़ता है। बहुत बार पेशेंट होता है कि दे कांट स्टे फॉर 1.5 months फॉर रेडिएशन ट्रीटमेंट। Sometimes there is an issue that logistically radiation is not available in vicinity of your areas, so you choose surgery. But obviously, practically, if you say in T1, T2, everybody I think on same page, they prefer for organ preservation and go for radiation.
Yes, sir.
mostly CA larynx patient, they are coming, they want, I don't want to lose my voice, do whatever you can do, so they prefer radiation. Then later on, when there is a recurrence, they go for surgery, but initially they just deny. So this is the problem.
So, sir,
I
my
guess,
take
sir,
is what is the surgical salvage is always difficult. What I know after post radiation to manage a patient when the residual disease is there.
After surgery, after post radiation.
After radiation.
Yeah,
surgical
after radiation, yeah, it's not so much difficult because nowadays we are giving radiation to the limited area. It's very stamp ticket size of treatment is there. So only that area is affected. So that can be taken care of by surgery.
Okay.
So there won't be any problem. Now,
Sir,
the similar question. Yeah.
Comment on IMPT, sir. Proton therapy, sir. Some glimpse. Give your some idea and thoughts, because these are the things right now emerging everywhere.
Yeah. Proton therapy is Dr. Ayush.
Proton therapy, sir, is now the buzzword in field of oncology where everyone is talking about. But still, sir, it is a very new technology. Long-term data are still not there. So people are not very sure that what will be the future of proton. But yes, as per the preliminary data, initial data from many trials and meta-analysis, it has shown beneficial effects when compared to photon therapy. But still, because like in India only, there are only right now 2 centers, so the data is lacking. So once there is a concrete data on proton therapy, then people would be more comfortable, and we would be more comfortable in discussing the effects of proton therapy when compared with photon therapy.
In
I
fact,
just want to say,
Dr. Ayush, how many years do you want
Dr.
for
Sonia?
the maturation of
yes,
data?
about all these new technology, proton therapy, IMIT, IGIT, because we are very familiar now with IMIT, IGIT. Every center, these facilities we have, and we have lots of data. What is the response? What is the toxicity? Response is same. These are the different new gadgets actually, proton therapy, and what we have we have different gadgets. So in a particular patient, what treatment is suitable in a selected patient, we choose it and then advise to the patient about treatment. So this proton, it doesn't mean that this is a very, the technique is like that, that will cure the cancer. Either that is a response with the photon or with the proton, almost the same, but the new actually new technology is that what are the recurrence cases and the sites where the toxicities are less, then we prefer the protons. So that's why this is the things. It doesn't
Moreover,
mean this is the curable too.
for the deep-seated tumors,
Yes.
For the
yes.
deep-seated tumor, this proton therapy is good, not for the laryngeal tumors.
Yes.
Laryngeal tumors are
Yes.
very superficial, so they can be treated with Gynec.
And the sites
sir,
where the
and for-
organ hit risk very close to the target, so we can use these technology.
And I think for
proton therapy.
laryngeal tumors, cobalt therapy is still
Yes, yes.
an
it's still
ideal-
That's good.
very
ideal
Stamp
technique
ticket
to
planning.
treat.
Stamp
Yes, sir.
ticket planning.
Even
yes.
in breast carcinoma, still we talk about 3D
Yes.
CRT, although IMRT,
Yes.
IGRT, we have everything, but
Yes.
still 3D CRT is gold standard. Likewise, in brain tumors, 3D CRT is still gold
Yes.
standard as compared to
Yes.
IMRT. So
Yes.
still we have need to think that whether this new technologies are actually
first-
will overtake
yeah.
the previous thinking or not.
Dr. Ayush, for the surgeon, can you explain radiotherapy related toxicity? That's important. Because Dr. Alok is
Even
very
for
much concerned.
patients.
Yeah, even for the patients.
The
Short-term and
radiotherapy
long-term
toxicities.
toxicities.
The radiotherapy toxicities.
Yeah, radiotherapy related toxicities.
So if in oral cavity cancers, if we see that majorly there are two complaints. One is mucositis and second is dysphagia. So, but recently, like with new technologies, IMRT, we have recently started, like what previously in IMRT, what we were doing that if like suppose tongue is a target area. So, but apart from tongue, the other area, the other soft tissue area, machine used to dump dose in that area, due to which there were more side effects, more reactions in terms of mucositis or dysphagia. So now we have started giving that area also as OAR. So now the dose dumping has reduced. So mucositis or this incidence of dysphagia, like we have started DARS also. So in such cases, we have reduced the side effects like mucositis, but otherwise the major side effects which we see are dysphagia and mucositis. And if the patient does not properly follow the instructions, then we may see skin reactions in form of dermatitis also.
And xerostomia.
Xerostomia is
We
common.
forgot
Radiotherapy
to
xerostomia.
introduce.
Even IMRT cannot reduce xerostomia, which we study in
We'll take a
trials
break.
and-
We'll take a break and we forgot to introduce Dr. Pankaj Goyal. He is with us because since yesterday, I think he was not picking up the phone. So I think so. You must be, you can go ahead.
Dr.
Hi, sir.
Pankaj.
Hi, good evening, sir.
Good evening. How are you?
All good, sir.
How is Rajiv Gandhi going?
Sir, as usual. But interesting discussion.
Dr.
Quite
Pankaj
informative.
Goyal is well-known medical oncologist. He is in Rajiv Gandhi. And Dr. Pankaj, would you like to elaborate regarding chemotherapy in advanced head and neck cancer and radiosensitizers?
So, I think that's a good vast topic, I should say. So, if you talk about, we'll divide it like radiosensitizer and then we'll talk about systemic therapy.
Okay.
So, radiosensitizer, like basically, if you talk commonly, what is commonly used is you close your eyes and usually the patient goes for cisplatin. If the patient is platinum, fit for a platinum therapy, then they go for cisplatin. Now, we have had data in which we can add some other biological agents with the cisplatin, which can augment the effect of radiation further. So traditionally, it has been cetuximab, which was being used. But now I think with this biomap, things are switching that even the Indian guidelines, they have switched to a combination of cisplatin and biomap, which happens to be cheaper. So if patient is not fit for cisplatin, then patient may go for carboplatin. And if we are giving cisplatin, then usually there's always a debate, how many cycles. So grossly, if patient is getting 200 mg per meter square cisplatin, then that solves the purpose. It would be 6 cycles, it could be 7 cycles, depending on the tolerance of the patient. If the patient taking it regularly, then usually the 7 cycles. So that is grossly what we talk about the radiosensitizers. And we talk about systemic therapy, then I think we can have doublets, we can have triplets. And depending upon how much patient can afford, we can add the biologicals. So if the patient is going for, you can say a NSCT type of approach, in which say radiation people or the surgeons have decided probably we want a response and then we will reevaluate. In those typical patients, we plan that we give a triplet therapy. And if the patient is say for a palliative sort of thing, then we actually discuss about all these options, that adding pembrolizumab in first line therapy, or we add cetuximab. Otherwise, the patients go for usually doublet therapy, and if depending upon the PD-L1 score, whether it's more than 50% or less than 50%, or the CPS score, then we decide if the patient can afford, then it's best that we add biologicals in upfront, though that can be used in second line as well. But best responses are when we use them upfront with chemotherapy or without chemotherapy, depending on what is the PD-L1 score, whether more than 50 or less than 50. So that is, I think, outline. What should I say?
When do you consider for immunotherapy in these advanced cases or early cases? Where?
So it has to be used in advanced palliative setting, not in definitive setting. So
Yes.
it's not yet approved in NACT, you should say. So in advanced stage, when you are not contemplating a definitive therapy, it's basically a palliative thing, like a recurrent or stage 4 disease, then actually you think about PD-L1 inhibitors, especially so when the patient's age is high, like pages elderly. Then when we are shying away from chemotherapy, then we give stress on it that we check the PD-L1 status. And if the patient is having a good PD-L1 status, then probably in these particular patients, we can try this single agent as well. And if the patient's PD-L1 status is less than 50%, then preferably we have to use it with cisplatin fludarabine 3 weekly. So the approved PD-L1 inhibitor is pembrolizumab among all the 3-4, whatever we have available. In second line, you can use any of them. You can use nivolumab or you can use pembrolizumab, irrespective of PD-L1 status.
Okay. So now in advanced cases, stage 3 head and neck cancer, what is the primary treatment of choice and why? Number one, surgery.
So I think when the patient is non-metastatic, always our goal is that we give some sort of local therapy. We always tell them we always tell the patients that surgeons and radiation oncologists should take the first seat and we should take a back seat. Because when we are talking about a local disease, a local therapy will be the best. Now, if a surgeon feels that he can do justice and take clear margins, or if the patient is not having a central type of disease, then obviously surgeons take over, or if the patient's fit. And if the surgeon feels that it will not be a R0 resection or the disease will be too extensive, in those particular patients, we actually put these patients in tumor board and then we discuss whether a front CTRT will be a good option or whether we want to see the bulk of disease, that we go for some induction therapy and then we go for CTRT if the disease volume is very high. So that is the thing. In stage 3, we plan that somehow if we give a local therapy, that will be good for the patient. So the PFS or OS will be better if local therapy could be added.
Good. So any other different opinion? Yeah.
Yes, sir. Sir, one addition, sir. Yes, sir. So in terms of radio sensitization, there is a data recently is going to publish from Tata. So when the patient is cisplatin ineligible, there is an option of weekly docetaxel. They have a lot of number of patients. Dr. Vijay Patel has done the research. So recently it is going to publish that we have one more option for radio sensitization. That docetaxel in a low dose in a weekly manner for the patient with very less
combination.
So with that, I think I should also bring up the another data by TMH, which says that you use nivolumab low dose with chemotherapy.
Plus OMCT,
though it was looking very exciting, but personal experience have not been very good. So
we have a good debate in Tata conference actually regarding the docetaxel issue. So they were very convincing. I don't know if we are going to publish it with a good result actually, and it has been accepted.
Data from a single institute is okay, but when you talk,
we were happy that okay, we have one more drug.
Hello.
Yeah.
लगता है
Dr. Saurabh asked whether on a single center study, are we comfortable or are we justified to make it a common practice in a single center study? Are we justified legally to change our practice?
So there are, my thoughts are there are always unmet needs in oncology, and we are always in the search of something meaningful and helpful to the patients.
Yes.
So if something is a right foot in the right direction, if you say I'm not very that.
No, I'm talking the legal terms. Whether
we have to
have advised something on the basis of TMS data.
So if it is in a large patient's data, it is a randomized trial. So why we can't use, because we have started using immunotherapy on the basis of single randomized trials. So why
No,
we can't use these
they got
drugs?
approval. No, they got international approvals followed by DCJ. So they had some approvals. They were not single studies.
So if
Single
you see, okay, I don't think carboplatin is recommended for radiosensitization and not a very good data, randomized trial data for using as a radiosensitizer.
No.
But we use it.
That is a standard guidelines inclusion
So
criteria.
I got it, the guidelines, but maybe later on it will also in the guideline. I think it will be in the guidelines.
Okay.
Because it was very promising. Whether you haven't got, we haven't seen that, but they have presented their data actually. So it was quite, and long discussion happened. That's I'm adding a point actually.
Okay.
That docetaxel is a possible option in future. Yes.
Right.
Actually, these are the centers which are doing research work, and we are going through the literature and we find out what is the best for the treatment. And we accordingly start treating our patient on those lines. So these are the few things: cetuximab, docetaxel in low dose, and cisplatin, of course, as a radiosensitizer.
And
So
then
that can
nimotuzumab.
be- Yeah. So in head and neck cancer advanced stage, where there are 2 or more nodes positive, lymph node, LVI, and PNI is present, we can go for CTRT, post-operatively, and other things. Immunotherapy, role of immunotherapy is also like that, only for the, that means for the failure cases, means elderly patient where we cannot do anything, we should try those. Any other thing which you want to discuss?
Sir, hyper progression by immunotherapy.
Pardon?
Hyper progression during immunotherapy. We should
Oh,
counsel
yes.
our patient. There is a fair chance. Sometimes
Oh.
the counseling part
Okay.
is
Why do they progress?
because 30% risk. I have seen up to 30%. The data showing that if you start immunotherapy, there is a chances of hyper progression of the disease. Whatever the reason, we don't, until and unless we do the
reason
NGS,
is this, that immunotherapy, it boosts up the immune system. It boosts up the malignancy immune system as well. अभी अपने बाबा जी बोलते रहते हैं ना, immune system बढ़ाओ, immune booster खाओ. That's the same type of
Hyper Babaji.
Yeah. So this is the type. He is copying our things, and we are copying
hypertension
their
is very
things.
very deadly.
Yeah, it flare up like anything.
Dreadful experience whenever you see. Yeah.
So I have one question with our medical oncology colleagues.
Yeah.
So I wanted to ask, like, in real world scenario, are we still using cetuximab? Because what we study in literature, it has good results. But are we in real world using cetuximab in now immunotherapy has arrived?
So that's a good question. Actually, now practically, if you talk about CTRT, nimotuzumab has taken over.
Yes.
And if you talk about systemic therapy, PD-L1 inhibitors have taken over because of the cost. So in same cost, you can use pembrolizumab, which is more promising. So it has gone down.
Now generic cetuximab came into the market. Maybe it will increase in few months.
Whether it is effective or not, whether to give or not.
Yeah,
that's the problem with the generic.
Because they are giving
when
like
it was
20,000.
introduced. Yeah, when cetuximab was introduced, it was all pharma propaganda, and they have clearly come out with that it is not at all effective.
Yeah,
and cost-wise, तो बिल्कुल ही नहीं है. So that's why
we
the
should
drug
talk
has
about.
not come.
We should talk about sir oral metronomic chemotherapy in this session also. They are the very helping drugs for.
You can go ahead with that. No problem. Your voice is breaking. I think you are somewhere out.
So I'll just add on what he's trying to say. We have this combination of methotrexate and this erlotinib and this NSAID, which can be used as metronomic, or you can use erlotinib or geftinib as such, or you can MTX tablets. So you can any of them, and many of these patients, these work very well. So that is also a good option with the patients not
very well.
chemotherapy.
Is there any role of injection methotrexate? Because I have seen many government centers use injection methotrexate also in such.
Yeah, that is also option. That is also an option.
We are forgetting our old things, and they are still working. You see, with the use of methotrexate, that was the only drug, and in head and neck cancer, it does wonders. But the disease come back equally fast. It regresses, but it will come.
So, sir, I have one patient at our synergy center that I have given OMCT actually, and he got so much response that he has got operated. But actually, we are not reporting it because we are waiting the survival. How much he is going to we have a recurrence-free survival. Actually, sometimes OMCT works very well. So we should always explore the option of OMCT in our practice because it works fairly.
Right, very true. So, anything to add? So, for the head and neck cancers, our learned specialists, they have explained everything, and whether to use surgery first or to go for the radiotherapy and chemotherapy together, and posterior radiotherapy, posterior chemotherapy and radiotherapy. Do you have any idea about posterior chemotherapy, or rather maintenance chemotherapy, I must say, for the patient who has...
Same, sir. Data is coming for maintenance OMCT in a high-risk patients who has been operated and surgical chemo radiation. Then they can be put on oral metronomic chemotherapy for maintenance as a maintenance.
What I have
so
seen
the data
in
is
my
awaiting.
life,
Still, it will be the next 4 months.
Yes, what I have seen in my life, this is very important part to prevent recurrence. Initially, you complete your course, whatever definite course is there. If there is a suspicion of smallest suspicion of residual disease, you must continue with the maintenance dose of chemotherapy. That will help a lot. So, thank you, our panelists. Thank you,
I just
Dr. Saurabh, Dr. Alok.
Hello, sir.
Dr. Pankaj.
Thank you, sir.
You were telling something.
Yes, sir. Sir, I just because in oral cancer, especially in the early stage, we didn't discuss about the brachytherapy. Brachytherapy has a very good role in the early stage cancer. So it is equal to
We were more concentrating on surgery.
Yes.
Okay, we go ahead with the early lesion because T1 lesion.
Because we have early cases.
Yes.
In our routine
Dr.
practice.
Paul is doing interstitial implant, and I had sent so many patients to him. You are also doing very good.
I'm also doing in the
and the results are fantastic.
Results are fantastic. Organ function preservation in the especially in the carcinoma lip, small lesion T1, T2, and buccal mucosa and tongue. So these are the cases that equally effective as a surgery and very good.
For the base of tongue also,
as well as survival.
Yes, base of tongue also. There's no other way to treat that.
But it is difficult to do. But routinely, yes.
In fact, in UP, interstitial implants nobody was doing earlier. Then gradually the people are coming in field. We also tried, but we could not get support. And Dr. Pal has started, and now Ramurthy, they are also doing. Yes, Dr. Ayush?
Yes, sir. So we are also regularly doing in tongue, buccal mucosa, base of tongue cases. We are regularly doing. Recently, we did one case of nasopharyngeal carcinoma also, in which within 1 year, patient had recurrence on the same side, and on PET CT there was no other met. So we did a balloon brachytherapy in that case. So in 1.5 years, we have done around 8 or 9 cases with.
Now we must promote this brachytherapy because interstitial implant is very important. Interstitial brachytherapy, and that is very good, and it's giving very nice result. And it is cost effective as well. Yes. It's cost effective.
Yes, within 30
Dr. Alok Tiwari,
the treatment is complete. And even in the recurrence cases, brachytherapy has a good role for a good salvage treatment.
We should develop more and more center for interstitial implants and give more and more training. Cervix, we are expert, but rest of the people, they are not doing. So we should promote these centers. Ramurthy is coming up, very nice. We have seen a few cases of theirs. And now Kamla, Kamala Nehru is okay. It was doing since long. So thank you very much to all the panelists. Thank you.
sir.
Thanks a lot, sir. Thanks.
Thank you. अच्छा अभी हैं वो आलोक भाग गए.
Yes,
Thank you all from my side also.
Okay, thank
All
you
the
so much.
cancer
Thank you for
work,
inviting. Thank you for giving this opportunity.
Thank you.
Thank you all for participating, and thanks for the technical support. Thanks for all the audience for patient listening.